it's,
Before I say for
a
sure.
glitch
And then,
in,
once I know for sure. then I'll
in our
say
meeting this month.
registration.
Yeah.
So she was available for that.
Yes.
But she's
She'll be the first
more than happy to come.
Okay.
And I think it's important because I think there's a lot of misinformation going on. And so
I was, yeah, well, I was thinking you had the same idea.
I keep telling her she needs to come here and explain what it's all about.
I can't remember all of my tribal design.
Report.
But I'm not,
The residential facility.
it's up to
I can't do
make that decision, but I don't wanna delay it too long since we want.
That's right.
But worst come to worst.
That
I
would
do
be cool,
have
then.
little
A lot of people
CIT
Yeah.
notes
You
So
that we could use.
what I'm trying to encourage,
Ones down the line, so I just would like.
you said you wanted me after, but what I'm trying to encourage
This will do, we have a minute or two.
is we have a lot of people that work in all these entities, right? And so there's no sense.
I like our old pin style, I just wanted like circle as opposed
You know, like,
to.
Especially
I just,
because, right?
Yeah.
Ignore was the one that ordered them before. We don't know where she ordered them from. I have.
but,
But it didn't say.
Like I go to all the facilities,
Years
so
ago,
I
so
can,
I.
you know,
You
write a
need to
little
figure
thing
out.
on it.
I have all the old CIT. files.
Raphael goes to play, you know what I mean? Like there's, so we don't. And I think it's important too for, like, maybe to have, the entity and maybe one of their success stories to come and talk about what
Yeah, I can.
What they got out of it, like,
I'd like to add to.
So that's what I'm trying to.
So we're in the executive, and you give us an idea like that.
Yeah, either way, I think it's, you know, it's important that they know that you are, they know what they do.
Yeah.
And, cause there's a lot of like,
And also to follow up on.
and then we don't need to like have a bunch of people.
Hello.
Hello. People want to.
Maria.
And pretty people that are on, in a official position.
Okay. The same role. Okay. I've been to these meetings a lot as a staff member, yeah, so. Never in this capacity.
Like, I can get people to come here, you know, what?
To hear from someone with experience.
Yes,
I think that.
not only the director or their institute or their medical, but we're totally down, but somebody that does.
Laura, did Omi tell you about the message I sent him yesterday about
So that's what
our personal freedom?
heard.
No, but I didn't know. The eagle has landed.
I did notice that.
Yes, which is good. It's what we were working with.
So yes, we can be that way.
Okay.
Now the rest of the plan has to.
What's up, handsome? How are you? I don't know you.
It's so much
Yeah, I see that. Oh, I did. Hi, Kat.
Hey.
Long time no see.
I know.
I know, I didn't hear the last time. You were here. And then we did last one.
I might have been on.
Fine. Laura?
Yeah, because I was- Nice to see you. Yeah.
Can I? Imagine that. What's the topic?
Mine.
What's the topic? Oh, I feel ya.
Yes.
How are you today?
Alrighty. We are at 12:16. I would like to call the meeting of the Behavioral Health Board. Wow. To order.
Felt like a break.
At 12:16. Joe, could you do the roll call, please?
Here. Marguerite Story Baker.
Margarita.
Raphael DiCaprio. Here. Bob Doherty, excused.
Here.
Natalie Royal. Virginia Bass. I'm sorry, did you read it? Is that my name?
Yep.
I'm here.
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 Are you present?
Right. All right, so I don't see anybody. So now, introduction of staff will go around, starting. All right, hi, thank you. Hi, everybody. Nice to see you. Emmy Box, Loretta, behavioral health.
Good afternoon, everybody. My name is Oliver Gonzalez, Program Manager for the Mental Health Services.
I'm Alex Childers. I use they, them pronouns. I'm career coach at the Transition Age Youth Division. Kaylee Emery, Deputy Branch Director of Children's Behavioral Health.
Paul Bugatti, Deputy Director of Behavioral Health.
Ina Holcomb, I'm the MAP Coordinator of the Humboldt County Jail.
Rafael DiCaprio, Substance Use Navigator for Providence.
Are we doing all of this?
No, if we could go back.
Actually, we already did the behavioral health for you. And if we, oh, and Natalie O'Neill just arrived. Going to Zoom, staff, you can start and popcorn each other. Thank you.
Hi, this is Sharon Wolf, Legislative Analyst with DHHS.
Starting with Christine. Popcorn.
Hi, Christine
Sharon, you're
Messenger,
muted.
DHHS Communications.
was Christine.
Sharon, popcorn.
Or do we not have audio? Cause it looks like, oh wait.
We couldn't hear you, Christine. Nothing. You're muted. She's not.
Can you hear me
She's
now?
good.
I'm not muted.
I can hear her fine, so I think it's on your guys'
Must
end.
be
Hold
them.
on there.
Is that working?
It's that little box below, I think, that there's a volume knob on it.
This one,
Is that it?
yeah, there's a ball, it's on
Oh,
all the
my
way.
bad.
Hang tight. We'll figure out the situation.
No problem.
And I just want to encourage everyone, if you're in the room, to speak up and out, project your voice so that everyone can hear. It's showing on.
Yeah, I think that's 31, that's the side it goes, yeah.
Oh.
Yes.
I like your background, Sonia.
It's not my picture, but I wish it was.
I know, I wish I was there right now. That looks delightful.
I want to have you type the clock again, please.
Can someone try to talk?
Can you hear us? Can you hear me?
Oh, for the.
Oh, that's what I can hear.
That's not as loud, but.
Is that a yes? I know we can hear each other on Zoom.
I know I can check the owl volume, or the owl.
Yeah.
You can just put it in the chat.
Thank you. Okay, there we go. Are y'all able to? Would one of you try to speak real quick?
Can you hear us? Is that a yes?
Yeah, I know, right?
Yes.
All right. Hi, Christine Messenger, DHHS Communications, popcorn to Sharon.
Hi, Sharon Wolf, Legislative Analyst. And I'll apologize ahead of time. I'll need to leave the meeting at 1 o'clock for a different meeting conflict, but good to see you all, and I'll popcorn to Sonia.
Hi, everyone. Sonia Levy Boyd, she, her pronouns. I supervise the Humboldt County Transition Aid Youth Collaboration, and I'll pass to Kelsey.
Hello, everyone. Kelsey Reedy, they, them pronouns, youth organizer with the Humboldt County Transition Age Youth Collaboration, and also with the Humboldt Juvenile Justice and Delinquency Prevention Commission. I'll pass to Marcus.
Hello, I'm Marcus. I'm a TAY and YAB member in Humboldt County.
I'll popcorn to myself. Hi, I am Melissa Nelson, patient navigator at Aegis Treatment Centers here in Eureka. And I will give it to, did Gina go yet?
No.
Okay, Gina.
No, I'm Gina Turner. I'm a medical office assistant for UI. I'm here just to take notes for Oliver.
Eddie?
Sorry about that. I'm Eddie Morgan. I'm the Executive Director of Tri-County Independent Living, which is mission is to help people with disabilities live independently. And I think I was the last one, so I think we're good to go. I think. Was I the last one? Yes, I was.
Thanks so much. Thanks for your patience, everyone. Peter.
I was locked out.
Oh, no. Peter Stoll has just joined us, as well as, I guess, Paul snuck in. Oh, no, you were here. Sorry. Are there any adjustments to the agenda?
Looks like he's asleep.
All right. Hearing none, we will go to public comments. We ask that you take 3 minutes and keep your comments to DHHS behavioral health issues. Anybody in the room want to make a public comment? Online, on Zoom, is there anyone who would like to make a comment? All right, hearing, you see a thumbs up. You do, who is that? That's us. Oh, no, Eddie.
I'm sorry. I was just saying I was good to go. Doesn't mean I didn't put my hand up, but thumbs up.
Great, thumbs up, thanks.
Laura, sometimes I get confused when we talk staff or staff on the behavioral health department, and those who are on staff of auxiliary organizations that work very closely with us, and maybe that doesn't matter so much. But sometimes I get confused about those who are also then a member at the same time as the staff member. So I get confused. Me too.
A member who's a behavioral health board member versus a
Behavioral health board member and a staff and an associate or auxiliary business. I don't know what to call them. We could talk there. Not the big one, but I get confused easily.
Who belongs to what kind of?
I'm sorry, what?
Who belongs to what?
Yes.
I get that. Okay, let's chat later, thanks. Like, make that definition. So now we're moving on to action items. I hope everyone's read the minutes from 11/21/24. Does anyone want to make a motion?
Make a motion to approve the minutes.
I have a correction to the minutes. Let's make the motion and second first, and then we can go to.
Second.
Right, thank you, Sean and Tim and Marguerite. You have.
So it's just a small correction, under number 9, floating leave. What is, the correction is that it says that, I visited Feather House, And they are also opening 2 more facilities, including a 6-bed women's facility. They already opened the women's facility. It opened in June. And I am not aware of another facility that they're opening. So they do have another men's facility besides the one that Eric Thompson and I visited. And they already have an open women's facility.
So the correction is that they opened a facility, 6-bed women's facility. Okay. Any other corrections?
I was present at the meeting, as against.
Yes, you were. Thank you. Any other? So with those 2 corrections, we'll take the vote. All in favor of approving the minutes with corrections, say aye. Aye. Opposed? Stand asides. All right, those corrected minutes are approved. Now to other exciting action items. We'd like to approve sending the membership application for Peter Stoll to the Board of Soups. The executive committee met with Peter, Sean, Tim, and myself. And we are excited and wholeheartedly would like to.
It was unanimous.
It was unanimous.
And the hearty welcome and glad you come to us with these gifts.
So if anyone would like to make a motion and second, and then we can have an introduction.
Second.
Move.
I'll make a motion.
We need the first motion and then second.
I'll make a motion to approve. the-
Thank you, Sean, seconded by Deb. And with that, Peter, would you like to give us a short introduction of yourself?
Sure. Nice to see you all, some familiar faces, it's not as much, but, I am Peter, it's pronounced Stahl, for the record, but it's okay, I'm flexible. And I am the Director of Prevention and Intervention Services at the Humboldt County Office of Ed. I am trained as a school and counseling psychologist. I came to Humboldt originally to do my postdoc at the counseling center at HSU. And then I came to Humboldt for a year 24 years ago. So I started working with the Humboldt North CELDA as a behavior specialist, the first behavior specialist actually in the county. In 2005, and I've been with the organization ever since. And so there's been some big changes over time with my charge and the work that I've been doing. We've been in partnership for some time with Children's Behavioral Health, most notably for the past 6 years with Humboldt Bridges to Success, which is transitioning Humboldt Bridges to Wellness, a collaboration that continues to happen. And there's some support that has come from the Department of Health and Human Services for the school climate transformation work we've been doing with multi-tiered system support, restorative practice, social emotional learning, those types of things for our school environment. Also oversee school safety, crisis response, mental health, foster homeless youth that all resides in our department. But of course, we do a lot of cross collaborative work. I've been very interested about this board for some time, and knowing that it would be really great to have some interface with education and represent some of the work we're doing. And not to take too long, but I also want to highlight some of the work that we're focused on right now. The county offices and with our interagency leader team and our ILT work with AB 2083, if you're familiar, but really looking at expanding the landscape of children's behavioral health in Humboldt County by creating integrated systems that are responsive to all students, but really focusing as well on homeless foster and juvenile justice involved youth in our community. So really into the idea of breaking down the barriers of our silos and integrating our work, having strong collaborative relationships. So I feel honored to be here and happy to engage any and all of you.
Thank you, Peter. Peter Stahl. So with that, I will ask for the vote. All in favor of recommending Peter Stahl to the BOS, favor, Sue? Aye. Opposed? Stand aside? The ayes have it.
Guys, how did that? Congratulations.
Yay. Welcome on board.
It was a difficult one to go back. I know. We can tell. I know.
All right, next,
Some friends. Yeah.
next on our agenda is another exciting recommendation. The executive committee met with Alex and would like to recommend wholeheartedly.
I will move that we, not, is it, oh, I got Tim, shut up. You know? I will move that we, support to have Alex, recommend that she go to the Board of Supervisors as one of our members. So.
All right, first and second, and with that, Alex, if you would mind giving us a brief introduction of yourself, and thank you.
Yeah, sure. Hi, I'm Alex Childers. I use they, them, or AM pronouns. I'm a peer coach supporting the Humboldt County Transition Age Youth Collaboration. I'm also a co-facilitator for the Alternatives to Suicide Peer Support Group and an advisory council member for the Sorrel Leaf Healing Center. And I also have lived experience in several systems, including foster care and having been homeless. I have received services from Children's Behavioral Health since 2015. I've also received services from the Transition Youth Division, from Wild Souls Ranch, various other systems in the county. So I've had experience with suicidal thoughts since I was 8 and navigating the systems thereof. And so I'm really excited to be able to share my lived experience and my experiences navigating our local behavioral health system in a way that can hopefully make things more accessible, more user-friendly for the next person to access.
That's awesome. Thank you. And all I can say is that I would someday like to work for you. Your interview was amazing. We were so impressed with all that you do. And so with that, I would like
I
to,
just want to say,
oh,
you bring so many different experiences and skills. I don't remember the last time we had someone, hey, it's been a long time, but a young person has all of those skills and experiences. I'm so glad that you're here. Yeah.
thank you. Yeah, so very excited. I'd like to take the vote. All in favor, recommending Alex.
Aye.
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 Opposed? And stand aside. All right, so with that, we will send you on. And excitedly, oh, Connie Beck is either waving, she has.
My glasses,
So-
it looks like.
These recommendations will go to the Board of Supervisors and hopefully they will quickly confirm them, and then we will have a full board. And just to let you all know, we had 3 other applications and they've been notified that we have these positions to fill from education and TAY. So we are now totally compliant with what the state wants for a behavioral health board, and I'm very proud of that. So yay, thank you. Celebrate these things. And with that, we will move on to the man of the hour. The MHSA stakeholder meeting.
Hey, good afternoon, everybody. My name is Oliver Gonzalez. I am a program manager for Behavioral Health Branch, and I oversee the Mental Health Services Act for us here locally. Thank you for the Behavioral Health Board for hosting this meeting. I really appreciate the opportunity. In today's meeting, what I hope to accomplish is 3 things. So the first one is to share with you information about what the Mental Health Services Act is and what it does locally here for us in Humboldt. Secondly is going over some really brief Proposition 1 updates. And lastly, but more importantly, getting your input, feedback, or even questions about our planning process, or just overall the programs we intend to fund in the 2025-2026 annual updates. But before I officially get started with bombarding you with information, we have a demographic survey. That survey is in your packet, which I hope you did pick up on your entrance here. This survey just kind of lets us kind of document who we've contacted through our meetings. It's voluntary and anonymous. For the folks that are joining us virtually, we actually have an electronic format to this survey that my colleague Gina has probably already dropped in the chat. I can probably do that again. And the end of the survey for you has a portion for comments. So if for some reason maybe you think of something and you don't have the chance to share it in today's meeting verbally, or maybe you think about it after the fact, this is your spot for you to fill that out. And additionally, there's contact information as well here on the survey, but also throughout the packet as well. And again, this packet right here, this community packet is for you to keep. It's just to have very condensed information of our plan, but you're more than welcome to also go to our website and have that plan. And I believe I forwarded to this group ahead of time too. So there's that. And I'll make sure you all get copies of the PowerPoint presentation slides at the end as well. And then for our folks joining us virtually, we are going to also include some contact information for you as well. So that way you can reach out if you have any questions, concerns, or any comments or recommendations as well. I also have our contact information here as well, which will also be shared for folks joining virtually in the chat, but also the packet has that too. So that's there for you as well to get a hold of me through email. If you have other thoughts after our meeting that you want to share with me. Okay, so with that, let's get talking about the Mental Health Services Act, or I'll just call it as the MHSA for short. It was established back in 2004 through a Proposition 63, which established a 1% income tax exceeding $1 million for all of Californians who have that income of greater than $1 million. One fun fact that I like to tell people is that that's going to be on the test at the end of this meeting. Okay. I promise. But it's that there are only 2 states in all of the US that utilize tax revenue to fund behavioral health services. The other state that does this is the state of Washington, and they do it in the form of a 0.1% sales tax. And something about their sales tax is that the counties have to opt in to do it. So they have the ability not to do it. With us, it's for all 58 counties in California. So again, on the test. So how is that money kind of gathered and how is it distributed? So essentially that 1% income tax for greater than $1 million, the state treasurer collects it, and then it gets subdivided to all 58 counties and 2 city jurisdictions, like Berkeley being one of them. Essentially, all counties, as we see in the, I got a laser pointer. So 95% of the funding is distributed to the counties using a really fancy formula that takes account population density. And then 5% gets allocated to state agencies, such as the Department of Healthcare Services, the California Behavioral Health Planning Commission, Healthcare Access and Information, Mental Health Services and Oversight Mental Health Services Oversight and Accountability Commission, and the Department of Public Health. And I'm really proud that I just got those right.
Really good.
Right, yeah.
I have a question. Just, how did, you said Oakland and what other city?
Berkeley.
Okay, so, and I'm curious if the counties still get the same cut. It's just interesting that those 2 are carved out.
Yeah, because their city density was deemed large enough to be considered. They have a city density of about greater than 150,000 people alone.
They kind of considered it as their own.
Yeah, they kind of consider it as kind of its own independent county in a way. Yeah. It's a great question. So that's kind of the MHSA and how the funding kind of gets allocated. But what do we intend to do with this funding? So we want to expand best practices and recovery-focused mental health programs. We want to reduce the long-term negative impacts resulting from untreated mental illness. And we also want to prevent mental illness from becoming severe and disabling. Okay. With that funding, we have to follow very strict, very specific requirements. And this just condenses some of like the bigger picture stuff, but it's a lot, so much so that it's almost like 300 pages of regulations. But essentially, we need to complete a 3-year plan every 3 years. With our last plan for 2023, 2026 being approved by our Board of Supervisors on June 27, 2023. Then we have to do 2 annual updates for years in between. So that means that we did 2 annual updates, with this one being the second one for 2025, 2026. And we also require a community program planning process, which is essentially meeting with community partners and getting that feedback for programs and planning. And you may be wondering, who would that be, right? Who are the people that we meet with? And that's literally everybody in our community. Anybody that has any ideas of our behavioral health services and our planning process is welcome to join us. Anybody who has lived experience. Again, we want to reflect the demographics of our county, and this is a plan that is very community driven. We want to make sure that our planning is responsive to community needs. So with that in mind, I'm gonna get started talking about our actual planning of the Mental Health Services Act for our annual update 2025-2026. Our MHSA right now has a estimated funding in our budget of $11.2 million. And I say estimate because everything is in draft form, meaning that it can be changed or adjusted accordingly. It's not really set in stone until it passes in July 1st, but we'll get to that later. Our MHSA is consisting of 4 separate categories. We have community services and supports, which takes 73% of overall funding. We have our innovation category, which takes 5% of funding. Our prevention early intervention, which is 19% of overall funding. And our workforce education and training, which is flexible in terms of how much funding we can allocate. And right now we have about 2% of overall funding planned for that category. And you may be wondering, why are those specific percentages like that? It's because of state regulation. They kind of dictate how we should be allocating funding to each funding bucket. So with our biggest service category, community services and supports, these are the services that have wraparound services essentially. So for instance, I'm not gonna go into great detail with all of them. I'll highlight, for instance, our very first one, which is comprehensive community treatment, also known as our full service partnership. And I'll also go over our travel support, crisis residential treatment, and the new one that we're proposing called CARE. But essentially what full service partnership does, and like I kind of mentioned, it's our wraparound services. It provides intensive community services and supports, such as housing, medical, educational, social. It takes 82% of overall CSS funding. And it's estimated to help 300 individuals annually. One thing about our FSP that I really like to highlight to folks is that the state likes to kind of use a term called the whatever it takes approach. Whatever it takes to get that individual stabilized in a safe place and house is what the program does essentially. And which would explain why it takes such a big chunk of the CSS funding. Then we have our crisis residential treatment facility. I really wanted to highlight this one because some of you may know it as Hyperion. It actually opened later, the later part of last year. I think it was around October 2024. And it accounts for 10% of CSS funding, provides crisis treatment to DHHS behavioral health referred clients. It is contracted with Willow Glen, and we have 10 beds available for DHHS clients. Up next is another kind of new addition to this plan, and it's called tribal support. So based on previous stakeholder input, we've been contacted by the Euro tribe specifically to want to become an organizational provider for us. So that's setting up infrastructure to build Medi-Cal and all of that. And these funds are intended to help that organization become an org provider and support them with creating Medi-Cal billable services that serve their community. Historically, we've actually used funding like this before with Two Feathers, who became our first Native American org provider. So I really wanted to highlight this because it's a really important need and it's something that previous community partners have mentioned to us as well. And then for the last program that I wanted to highlight under CSS is a program, Crisis Alternative Response of Eureka, also known as CARE. This is estimated funding for roughly 1%, $112,000. And it's a partnership and collaboration effort between the County of Humboldt, city municipalities, and other organizations. It's intended to provide person and family centered care that can de-escalate and resolve crises before more restrictive interventions become necessary. So again, more at the human-centered right approach of wanting to be direct before any other restrictive, more intensive interventions come into play. Okay, so up next, we have our innovation category, which I said earlier that it takes about 5% of overall MHSA. We only have one innovation program. It's called Resident Engagement and Support Team, known as REST for short. We have estimated a little less than $450,000 for this upcoming fiscal year. And what made it innovative was that it creates an increased case management and peer support for people who are experiencing homelessness or at risk of becoming homeless. It estimates to serve around 100 individuals annually. And this was a project that was approved by the OAC back in June 2021. One thing I really want to highlight about innovation projects is that when approved, they can only be funded through innovation for 5 years. After those 5 years are over, that program needs to have a different funding source to keep itself afloat. So one way that I really like to describe innovation is that it's like seed money, essentially, to help us try something new. And something new, for instance, could be, wow, I see this other county doing this other thing, this other really cool program. Let's bring it here at the local level. That's the heart and soul of the innovation category. I think I saw your hand go first.
I'm sorry, I just need to back up for a second, because something you just said a few minutes ago, kind of, I just have to question.
Okay.
So you said something regarding, doing whatever it takes.
Yes.
What does that look like?
That is a great question.
Cause I see a lot of barricades, and so like, I just want to. Is this a future thing that we're doing, or is this, or, like, what does that look like?
Yeah, that's a great question. This is a question that I would actually have one of our deputy directors, Jack, answer, but it's not here. But one thing that I can say about the whatever it takes approach is, for instance, like if you have somebody who got referred into our system of care, right, and needs transitional housing or emergency housing, like at a hotel stay, as an example, that is one intervention, as an example, that our full service partnership fund, as an example, right? So again, it really is rooted into how fast and responsive we can be, ultimately. That's really the extent I can personally discuss with you at this point, because again, I'm not one of the service providers for that. But if you like, I can reach out to our deputy director, Jack, and see if he has more information that we can share.
Yeah, I just want to know more about what that looks like in the future.
And I do actually have some slides about how it can look like in the future, because that is something subject to be adjusted.
Yeah. I love that word. That's why I'm asking questions.
Yes.
A lot of things have been like very not black and white, but just this is the way it is. So like when you said that, it was like, yay, we're finally like, because not everybody fits the same criteria or looks the same as everybody else. And so like, yeah.
It's a really good question. And I'll address some of that too in later slides at the end too.
Okay, thank you.
I think I saw.
Sorry for interrupting.
When you give us a number like 100,
yes.
Is that an aggregate number?
Yes.
Is that these number of people have actually contacted and used our services?
That's just a rough estimate. Sometimes it can be around 80 or 90 per year. It's just kind of like a goal that we try to aim for the next fiscal year.
Okay, some places might say our membership is this, but it changes, it shifts. that number is kind of a vague or average number, but you're talking about this aggregate. Okay, thanks.
And Vernon, can I answer your hand?
I know this is a remake for you, but when you say innovative ideas from other counties, like Stand Against Stigma in Shasta County, which is a speakers bureau. They have touched 5,700 individuals throughout Shasta County by their public speaking. Would some of this $444,859 be able to pay for this training, or how would that look if we were able to get into the innovative with Stand Against It?
Great question. So ultimately, that funding that you see right there is specifically for that program, right? However, if there's like a proposal or a need for an additional innovative program that gets suggested and approved by a behavioral health director, right? That is something that could be integrated into our plan. When it comes to innovation projects, it can get a little tricky in terms of the approval process, but ultimately, again, the starting point is getting that feedback from the community, right? So I know you've shared with us in the Hope Center, right? A very similar recommendation too, that will be reflected on our reporting so that leadership gets to see that, and hopefully maybe it will get implemented in some capacity in this plan, and if not in this plan, it could potentially be somewhere else. But again, just really wanted to highlight that piece that necessity for input, right? Which you're providing right now.
Okay, thank you.
But I can just add a little to that. The REST program really came from, all of the stakeholder engagements that you had throughout the county and all of the input that was coming in from the county around the need for people to, help them from falling into homelessness. So that's where the idea came from. So it came from the community input, which was really great. And the SOAC, that process for approval was pretty rigorous. I was surprised with how in the weeds that committee got and what they were asking of us as far as evidence and, to substantiate our proposal. So they don't take it lightly, and it's, I was impressed with the outcome too.
Can I add just a comment as well? I think it's also important to underline that when you say the approval process can be rigorous, it really is most rigorous at that stage. Like we as a community may say, oh, this is something we really want. And I'm like, yeah, let's lift that up. But then the approval process at the state level is where the scrutiny really gets pretty intense. I also think it's important to flag that innovation is a category that won't be quite the same with BHSA. And so because of the changing in funding, and I know Oliver's going to talk about this later, we may or may not use innovation in the same way because we have decreased funding in other categories. And so we'll have, again, as a community, need to decide, like, do we really want to do another innovation project, or are there other really critical funding areas or program service areas that are losing funding because of the changes to BHSA? So just like bigger picture, I think it's important to say.
When you say they about the rigorous, are you talking about the state?
Yeah, the oversight committee is really composed of a lot of subject matter experts. So they had really good questions, and we had to go back and do some work and bring it back to them, I think twice. But
did that seem helpful?
It was helpful. Yeah, it felt good that, there were some things maybe that needed to be clarified and tightened up, and they were all over that. So we tightened it up, and so I appreciated that.
Thank you.
So on the sustainability of an innovation project, so at the end of 5 years, sometimes do innovation projects move into the CSS category? Or did they have to say, after 5 years, this is how we're gonna keep going?
This is the latter part. After 5 years is how we'll keep going. And it's all kind of like what Paul and Emmy are mentioning. It's all integrated in that proposal we get to the state to justify the innovation project. It's almost like making like an argument as to why we really need it. and we need to try that out. And any other questions? A really good question. Okay, so what I'll do then is I'll move on to our prevention early intervention category, PEI. Our PEI category, these are the services and programs that do outreach, access and linkage to services, suicide prevention, stigma discrimination reduction. They're services tailored to make mental illness for not becoming severe or disabling. I'm not going to go over the big list because I have another slide here that has other additions to PEI. However, I am going to highlight, of course, the new one that you see highlighted here at the very end and a couple others. So for instance, we have our local implementation agreements, known as LIAs. So these provide the opportunity for community-based organizations to apply for funding for projects that meet the PEI guidelines. To kind of draw a parallel with innovation in some capacity, it's a mini version of seed money for 1 year funding. For again, local organizations to try something that they want to develop at the local level. With the idea of after that 1 year of funding ending, they'll have other sources of funding to keep it afloat. A couple of organizations that are currently approved under that local implementation agreements are Bear River Band of Runner Rancheria, Centro del Pueblo, First Life Humboldt, Mato Valley, Northern United Humboldt, and Southern Humboldt Family Resource Center. So, and one thing that I really want to stress and highlight here too is our application process is hopefully going to be opening up in February. That's what we're aiming for, at least, for local implementation agreements. So, and that's an award of up to $24,900. So, when it clears for supervisors and all of that, I'll make sure to blast it to everybody, but just want to give you all a heads up in case you know any organizations that may potentially be interested as well. Up next, we have one of our newer programs that we're wanting to fund in this 2025-2026 annual update. It's called the Humboldt Early Psychosis Intervention Program, known as HEPI for short. It is 10% of PEI funding, around $250,000. And it is a program that is with the Transition Age Youth Behavioral Health Program. So it's kind of integrated with Dave Behavioral Health. And it is a youth meeting program criteria will be offered group therapy, individual therapy, family support services, peer support services, medication referrals, and case management. And one thing that I like to describe too for this program, it's here, it is considered a first episode psychosis program, also known as an early intervention program under our MHSA language. So that's.
To add really quickly, Dana Taylor, our supervisor over that program, is looking forward to making some time with this group to present specifically about that program. So I think that might be the month or two, depending on how we plan it out.
We might be able to time it too, by the way, and that's in the public comments section in May that I normally do.
Oh.
We might be able to integrate and kind of work off of each other in some way.
Yeah.
That'd be cool.
Cool.
Okay, now we have our last category of MHSA, Workforce Education and Training, known as WED in short. We have that estimated of $218,000, about 2%. And this is a category that essentially helps us train staff in our behavioral health system of care. For instance, it finances our Reliance e-learning system platform, which is an online platform that helps us with training distribution. And we're also aiming to continue using this funding to fund consultation with Native American consultation, more specifically about how staff can engage with Native American groups, right? And how to, again, just do equity trainings in general as well. So that's one section that we wanted to add to the workforce education and training component. Additionally, there's a tiny portion too for the Superior Regional Partnership, which is like a state partnership for us with Cal Mesa. And essentially they help us with recruitment and retention strategies as well. And that can be like in the form of loan repayment, graduate stipends, and peer scholarships. So I wanted to give that a shout out as well. So now we're getting to the section of Proposition 1. Okay, and one thing that I really want to preface about this Proposition 1 slides, which are very brief, and there's only like maybe 4 of them, is that these are just kind of a refresher, kind of to refreshing the need to have a conversation around Prop 1. There is a lot of information at the moment that I'm going through. The Department of Healthcare Services is actually providing this information in a series of volumes. So far, they've released 2 volumes. Each volume is 150 pages long. So it's a lot of information, and some of these volumes are still in draft form. They haven't been finalized yet. So again, the need is to kind of have a refresher of what Prop 1 will do to the Mental Health Services Act. And ultimately, to highlight the need that there's gonna be more future conversations to come as we get more information and we get to plan a transition to the new format. So with that in mind, that Proposition 1 will rename the Mental Health Services Act to the Behavioral Health Services, BHSA. In the beginning, I mentioned a state allocation of 5%, right? And the counties get 95. This is gonna double that allocation. So now the state is gonna get 10%, and then all 58 counties and 2 city jurisdictions will get 90% of funding. And then ultimately, it is going to restructure the behavioral health, the MHSA into new categories with new reporting requirements. So here we have a slide that kind of goes over how the new structure will be for BHSA. And one thing that I really want to emphasize and highlight here is that this goes live July 1st, 2026. So we have plenty of time to plan and prepare, but I really wanted to highlight that. So the annual update that I presented to you is obviously still gonna go in our same current format. In the new BHSA format, we have 3 distinct categories. We have the housing intervention, which is 30%. We have our full service partnership, which is 35%. And we have the behavioral health services and supports, BHSS, which is 35%. One thing about, as you notice, our FSP full service partnership is pretty big as is in its current format. So making it its own category makes a lot of sense. It actually takes roughly that percentage that it lists there. But you may be wondering, where is the funding coming from for the housing interventions? Remember that whatever it takes approach that I mentioned earlier for FSP, it's ungrading that FSP housing funding to its own independent category with the intent of having counties utilize that money in a more broader way. Of course, that comes with some concerns. As you noticed, we are getting less funding. So if we're going to be making this funding, the funding criteria more accessible in general, how many more people can we truly serve in this new format? Additionally, to kind of touch base on what Emmy and Paul were mentioning about the behavioral health services and support category, the BHSS category has a lot of things built into it. It actually includes early intervention, outreach and engagement, workforce, so workforce education and training is built into that. Capital facilities and technological needs, innovation projects are built into this section as well, right? So it's cramming everything that doesn't fit in the FSP category and housing category into this 135% section. So again, with the combination of less funding and cramming everything into one subcategory raises the big concern. Again, is there gonna be enough funding to do innovation projects in the near future, right? So one update that I have for y'all is around the early intervention component. Because the way the language was presented in the very beginning was that anything having to do with prevention, we couldn't really do in this new format. So those access to linkage to services, outreach, all of those were not originally included. However, based on the new language that we just got literally like 3 weeks ago, they're expanding that language to include some of that. So one quote that they have here is designed to prevent mental illness and substance use disorder from becoming severe and disabling. I really want to highlight that substance use disorder because that's a new addition to the early intervention delivery. Yes.
So recently I've come across a lot of people that have autism. Does that fall into that category?
It does not. It unfortunately does not. And are you talking more about which category are you specifically referring to?
If a person, let's say they're a mental health diversion and we are noticing signs of autism, but they're also on mental health, they have mental health challenges. And so I'm questioning because, I think it goes unnoticed and it's more and more, to me anyways, noticeable in our community. And so like, I'm just trying to see how, where is that one of those things that is, innovative?
I think right now with the language that we have, right, under this new format at least, it might not fit Kelly. Yeah.
Autism falls under a different system of care through the regional center system. And so the way California has mental health, behavioral health, and intellectual disabilities or other disabilities that they're separated with systems. And so it is a challenge because people have multiple diagnoses, but I don't know if others want to add to that.
I'd say that our youth serving programs integrate a lot of our work with the regional center, so there's a lot of crossover. But if autism is maybe diagnosed in adulthood, there might be a little bit less of that and maybe room for improvement there. Also, just to note, we can serve folks who have autism, but that usually isn't something that we can ameliorate with the services we provide. So, folks may have autism and depression. We can work with the depression and still work with that individual.
Right. Okay, thank you. Want to know about that innovation then?
Good question.
So again, this is just a general update on what early intervention will entail and how it was recently updated by the state. And here is another slide that kind of goes over specific aims to early intervention. Everything highlighted in yellow is new language that didn't exist in the Mental Health Services Act originally. So for instance, we have now self-harm being implemented. We have suspension, expulsion, referrals to alternative or community schools. That's something that they just expanded language-wise. And this last one, overdose, of course, because of the SGD component that they just added in early intervention. And lastly, this language already existed in some capacity, but they're highlighting it here because originally when Prop 1 came into play, they forgot to include this language and it panicked a lot of people. So that is mental illness in children and youth from social, emotional, developmental, and behavioral needs in early childhood. So again, it just got highlighted in yellow to really stress that it is part of this intent for early intervention. But that was really kind of like the main, again, kind of like a starting conversation, I guess, of Proposition 1, and then kind of a refresher that it's incoming, right? And that there will need to be a need for bigger conversations in the future when we get more information and we begin to plan for this new format. This slide right here that I have here, which is the very last one, I promise, is our planning cycle for the Mental Health Services Act annual update. So we started our plan in September. We started developing it, and then in December through February, we're meeting with community partners, making sure that, we're getting as much feedback from everybody as possible. Then we generate something called a stakeholder report, which our leadership is reviewing it, and then that could make changes to our planning and what we include for programs and our budgeting. And then in May is when we have something called a 30-day public comment period, where we blast our near final plan for everybody to read in our community. And then on the very last day, we have something called a public hearing, which normally the Behavioral Health Board hosts. And that's kind of the final day for input. You got a presentation from me as to how our meetings went. And then if everything goes well, by July 1st, 2025, we'll have a fully executed plan that will go to Board of Supervisors for approval, essentially. And in the middle of all of that too, by the way, we're expected to get more finalized language around Proposition 1. Which again has been really slow in getting that language. I was hopeful that we could start those conversations last year, but unfortunately, we just started getting that language. So I get to the kind of old Paul, because I heard someone say this, it's like drinking out of a fire hose. It's a lot of information. It is 150 pages per volume, and we only have 2 volumes right now, and we're expecting 5 to 6 volumes. So, and fun fact, those volumes are not in final form yet. So I'm gonna have to go back and reread them when they finalize them, which is hooray, yay. So with that in mind, that concludes my presentation. Thank you so much for listening, and I would like to open the floor to you to again share any feedback, any additional questions you may have, or any recommendations. Again, thank you so much for having me here. Appreciate it.
Thank you.
Questions are coming.
I'm gonna open our chat too. Okay, they're just commenting on the sound. We'll start here, yes.
Okay, I have to say that I'm happy that substance abuse is being included in this now. That's a long time coming and a good thing. But I am really concerned about the fact that the money has been reduced. And yet a huge category has been added for, that. Did you feel that, during the, meetings that went from September on about that the substance abuse community was pretty well represented and ideas were coming from that end of things?
That's a great question. So I haven't met specifically yet with SUD specific groups or advocacy groups. So if you have anybody on mind or groups that I can reach out to, please let me know because I'm still reaching out to people. So I would really like any points of contact.
I can do that for you.
Thank you so much.
And Raphael too.
I will be all perfect.
I just had a question about the community services and support. So the funding that's listed to support care and the tribal support, what exactly is that money being used for and how is it being used?
Good question. So for care specifically, it is intended to help with additional staffing needs for behavioral health services.
So it would be going towards their staffing. Okay, so it's only that 112. There's other monies from a different pot of money.
Yeah, that 112 is actually we had conversation with them around their staffing needs.
Sure.
And so that's what's allocated out of this fiscal year for MHSA, and we have a similar amount. So the total will be about double that for a year of support for their staffing.
That makes sense.
Yeah.
And then your second.
Tribal support. So you'd mentioned the Yurok tribe wanting to be an org provider. So how would that $87,000 support that?
So right now, that's earmark that we have right now to be responsive to them. We are still engaging in conversations with them to figure out what the need is. That just gives us the flexibility to just be responsive.
Okay.
I just wanted to say, I appreciate your thoroughness and your professionalism, with your reporting. And, a lot of questions got answered and, I just wanted to tell you that I appreciate all the hard work you put into this, because you can tell that it's not just willy-nilly stuff that you're throwing out there. It's been thoroughly checked out. So I just want to tell you how much I appreciate the hard work you're putting in.
Amen.
Yeah, thank you.
That's all.
Sorry, ditto to Danette, and sorry if I'm pointing these questions at you, you were the president. So for the innovations funding for the REST team, is REST working with people that are currently experiencing homelessness or people that are already in housing? And I realize the deputy for that program's not here, so I'm not sure.
Yeah, I think it's a combination, but really the intent is to make the housing successful. So either supporting as they're trying to access housing or newly housed. I think it's likely, I think Jack had recently said it's slightly more newly housed individuals that are getting those services.
That was my impression, and so I just wanted to be clear if they're actually providing outreach in the community to people that are experiencing homelessness.
Sorry, put some more hands? No? Maybe some similar questions that we already addressed? If we don't have any other,
Right.
if we don't have any other questions, please fill out your survey if possible. Add any additional comments that you may have, just return to me by the end of the meeting time. I also implore the same thing for our folks joining virtually to click that link and do that. But again, thank you so much for having me here. I really appreciate the opportunity. It's an honor.
Thank you. I'm sick. You don't have.
I can email it to y'all with the PowerPoint slides.
Thank you. That'd be
Okay.
wonderful.
Thank you.
Yep.
Thank you, Oliver.
Thank you.
Thank you all.
Okey-dokey. Next on our agenda is discussion, the HCTC recommendations review. Which again, I think that my hope would be that we could put this off until our new member is approved. Who we can just directly discuss, but does I don't know that we have any other feedback at this time.
So I can. I never do first, but I like to do first.
No.
Happy to do that if that's the consensus of the group, but I know we have, well, actually, maybe we don't have as many people online to talk about this now. Can't really tell. It seemed like there were a good number of folks from Bay that were here to weigh in on this. Was that clear that they weren't gonna do it today?
Sonya's up
There were a couple of people online. I just didn't know if people planned to come today to talk about this because it was on the agenda, then my hope would be that we like capture their thoughts, even if I don't know.
Were you able to review the meeting that you weren't at? I sent you a link to that meeting with what we had talked about. I think it was 2 or 3 meetings ago, maybe. Were you able to review that?
To watch the whole meeting?
No,
Was that?
the part that where HCTC had some comments about the recommendations that were made a few years ago and what our response had been to that.
I didn't watch that.
Okay. I think it had been mentioned that I would interface with you about that and see if you had any other input, since you're on the JJDPC committee as well.
Okay, my point was just if they're here and they have something to say about on the comment, I just.
Is anybody
opportunity
from, hey, anybody online who would like to make any comments or in the room?
Well, I'm gonna defer to Alex in the room, but I don't think we are really ready. I think I lost radar of this to bring it up again at this meeting, but with Alex hopefully joining the board and maybe a TAE subcommittee starting, or something more focused on the TAE age range, that would be a great place to start it. But we also do have Marcus, one of our members here online as well. So I don't know if Alex, you have anything else to add?
Yeah, I'll just add, so I did see it on the agenda, and so I came with like some ideas, but I think that if this were tabled to next month, that would give us more time to more fully bring our recommendations, a reminder of which ones we'd like to highlight especially. And so I'd be okay with tabling it. I've already got some thoughts about which recommendations to prioritize. And our youth advocacy board has done some work around this as well. So yeah, I also want to check in with Marcus, if there's any other thoughts you want to add. Totally cool if not.
Marcus? did you-
No,
oh,
I have nothing else to add.
Thank you. Okay, all right, so we'll just put it on the agenda next. Wonderful. All right, with that, it's time for communications. We'll just go around with board members, and I know that Vernon, you have something to share.
Yes, Vice Board Member. Thank you for the time and opportunity to share a new brief that was published December 2024 from the Center for Healthcare Strategy. It is entitled "What We Measure Matters: Centering Lived Experience in Developing Behavioral Health Quality Measures." I think that this was a very short but a very robust document. I did bring 15 copies today for people to take a look at. There are three key takeaways that you would probably get from the entire reading. Partnering with people with lived experience in developing behavioral health quality measures can help improve service quality and provider and payer accountability. Best practices are emerging for participants partnering with people with lived experiences in shaping behavioral health policy, program design, and quality measures. There are unique factors important to people with lived experience that should be considered in developing behavioral health quality measures. So if you would, please just take the time a little bit to read that. I would like to implement last year's May is Mental Health Matters Month theme, reimagining mental health. Reimagining mental health to me would be with more consumer involvement. Thank you so much for your time.
Thanks. Julie, do you have any communications?
No, but just a thought, Vernon. It seems to me that's really an important issue. The incorporation of lived experience in a more thorough and consistent manner. It's not that we haven't had that over the years, but it's been a little sporadic or one person commenting on things. And I don't know what that would look like to have a subcommittee and an ad hoc who develop more thorough and effective ways to communicate lived experience input into the work that the county does. Does that make any sense?
Yes, this addresses that. Oh, wait, on page number 4.
Okay, I'll read it then, thanks.
On page number 4, promising momentum for engaging people with lived experience. And that starts on page number 4.
Okay, thank you very much.
And that's a good question. Thank you.
Well, I have nothing else to say.
John, do you have any communication?
No communication.
Ms. Kelly?
I always have something to say. No, first of all, thank you for having me. This was my first meeting as a board member, so I'm happy to be here in this capacity. Yeah. But I just wanted, one of the hats I wear is coordinating the crisis intervention team trainings for Humboldt and Del Norte counties. And so we tentatively have our next Humboldt County CIT training scheduled for the week of April 14th through 18th here in Eureka at the Warfinger Building. We had one minor, we had to make some changes with our post certification for the law enforcement continuing education units. So we're just waiting for final approval so there's a small chance we might have to push it out a little bit further than that. But at this point, we're aiming for our 40-hour training to be that week. And then we plan to host a second training in July. So I will make sure to distribute the registration flyers once we have the dates solidified.
Who comes to these?
It's primarily aimed for law enforcement and other crisis responders.
Got all of us, yeah.
Yeah, but I will say our county, we've kind of expanded the model to include Del Norte County. And so we've been hosting 4 trainings per year for the last year and a half to going on 2 years. prior to that, we were only hosting one training per year, which made the spots limited. So we've been able to open it up to more and more service providers, which has actually been really valuable in terms of building collaborative relationships between law enforcement and service providers in the community.
Is there any room for first responders, paramedics, come with an ambulance in those situations? That
Absolutely.
they should be involved in the training?
Yeah, I mean, they're invited. We don't currently have representation on our steering committee. That would actually be a good thing for forward, which I will bring back to the CIT
They're
steering.
right in the middle of that.
Absolutely.
And you have a question?
I have a question.
Yes.
The last time you and I talked, I think you were saying that there's not currently or the ability for, you know what I'm gonna say, CEUs for other professionals, but you just referenced it for law enforcement.
Yeah.
Will that be an option going forward?
So when DHHS was the lead entity leading CIT, there was an analyst assigned to support with getting the CEUs processed through whatever tests. When I went to do that, without an analyst support, it was overwhelming and tedious, and I wasn't able to complete it. And so if I had support from somebody at DHHS to do that.
Okay. Maybe we could talk about that.
I would love to offer that again, because we do have plenty of clinical staff attending the trainings
It's such
now.
a need too.
And
Yeah.
we had the, clinicians, nursing and substance use disorder counselors that had CEUs available. So I would like to work on that.
Okay.
Again, and I probably have more capacity to do that now than I did initially.
Yeah, okay, so let's just talk more about it.
Sure.
Okay.
Thank you.
Hand raised.
Not clapping.
Eddie, do you
Yes.
have a comment?
Yes, I do. I have a quick comment. I just want to very much support the lived experience comments that we're doing. It's part of our philosophy at Tri-County. More than 51% of our board members have to be people with disabilities. And I'm going to be a little shameless here. And we have an open position for a systems change person. And I'm very much looking for somebody that has had lived experience so we can better assist in the meetings like this and moving forward with our community. So that whole concept of lived experience is very important to us, and we're very much looking forward to supporting it. So thank you.
Thanks, Eddie. Moving on, communications, Danette.
I have a lot of thoughts, that I'd like to talk about. So, I guess we're gonna have a conversation after the meeting, but I wanna talk about it, like, I, am hoping to be able to start having, our programs in the area, rather than having people go out to the facilities, and interrupt everybody's, confidentiality of the programs. I would love to start having, the programs or whoever, program and maybe, somebody that wants to share their experience rather than being an official in a program, come to this meeting so that they could share about their program. And then if there's somebody that lives there that wants to share their story, then they can tell of their experience. So I continuously say this, like, we have a lot of people in programs, and sober livings, et cetera, that have people walking through their place and they already have mental health challenges, maybe, concerned about who these people are, what they're, you know what I mean? And so, I would like to, have a discussion at some point about changing, just having people go through programs and having discussions with people off the, it's really an ethical thing. It's not okay. And so, I've continuously, talked about this, in other situations. But I need to say it out loud that we need to change that pattern it is not okay for us to be going through facilities. And, you know, and it's not okay. And so I think that we have a lot of people that work, with a lot of these entities that can, you know, that have seen stuff that's you know, how the housing is or whatever. But I think it's really important if we're doing, the shared experience thing, that we invite the people here to share what their, goals are. And, maybe a success, someone that's successful or whatever, or peer support, peer from there. I think it's important that we do that rather than break, people's confidentiality. It's no one's business who's in treatment. And even though we think it's okay, it's not okay. It's an ethical confidentiality thing. And so, I just wanted to say that out loud because it's not okay. And, I have continuously tried to detour this. And so I'm just saying it in the open. It's not okay for us to be just wandering through treatment programs and sober livings and thinking that it's okay. We have many people in these places that have mental health challenges. They don't know who you are. We're, you know, like, the second thing I want to talk about is, a lot of, sorry, it's hard for me to say because I think people are judging me, but the other thing I want to say is a lot of times with our people, people just show up on their doorstep and start directing them to do stuff. And unfortunately, the thing is many people don't understand that our clients, our people, our patients, our peers, our community, like if we're trying to get them to make better choices, they're not gonna just follow direction of somebody that shows up at their door randomly, that they don't know. And here's your medications, or we're taking you, like we need to be thoughtful about how, what that looks like, you know, in our community. Like I've had several experiences, not with, mental health here, but, with other entities where people just show up randomly at clients' doors for medications. These people don't know who they are, so why would they want to take the medications? You know what I mean? And so, I think it's important about people building rapport, and not everybody is going to act right when you first have contact with them. And a lot of times, if somebody doesn't act right the first time, I hear the word of, they're non-compliant. You know, we're not gonna work with them anymore because they refused this time. And so I think we need to revisit how we think about, the reality of life. You know, like, anyways, that's about it. Thank you.
Thank you, Jeanette.
May I say something? I really honor and appreciate what you said. And one of the things that struck me as you were talking is a little bit of history. We used to have an SUD board.
We still do.
It's a committee, not a board. And they were like an equal, and they had, that, in other words, when we merged together, our concern when that happened is that SUD would lose that larger workload and participation. And that it might become a committee, that doesn't have a voice or as much voice and active participation.
Yeah.
So what's sticking in my mind right now, to go with the executive committee, we put things in the agenda as ongoing. You know, whether it's care court or something like that. And when something's up there, they're there and we can add it to it. It seems to me to have SUD presentations about different programs or different issues on our agenda on a regular basis might facilitate that, so that you can bring those voices and those experiences here, is what I hear you saying.
Yes.
It's, do that on on a regular basis, so that you got another 10 minutes, you got another 10
Yeah.
minutes, however you think it works, Marguerite. So that we know more. I know there's a lot of stuff I don't know. There's my
I think it's important that the manager or whatever of the program or their, what's the word?
director? No.
Whoever they choose
Okay.
to represent the treatment program, they could come here with somebody that wants to be here.
Yeah.
We don't need to go into their house, like, I don't know, my house is my sanctuary. So like, I feel like when we're just showing up in people's housing, I know it's treatment, but it's still where they're learning how to live life. And in real life, people don't just show up at your door.
I'm trying to honor that for what I'm saying.
Yeah, and so I think we really need to think about how we interact with people. We have to build rapport with people before we think they're gonna gain our trust. And sometimes, I tell you what, I worked with a guy 4 years ago, the first day I met him, he threw a cup of coffee in my face. And at that point, I knew that this person has had a lot of trauma. And so 4 years later, he's housed, he's taking his meds, you know what I mean? Like, I just want, I'm starting to, there's a lot of correlation, I don't think I've ever really shared my story, but, I was homeless 29 years ago. And was told I would never work. And so like, when I think about how, like, people would say, you need to do this, I'm like, who the hell are you? You know what I mean? And so, people just show up randomly, and start telling people what to do. Instead of like walking beside them and showing them. And a lot of our people in this area, come from outlaw families. And so, just being blunt, come from outlaw families. So, people, we're trying to encourage them to do the right thing, but everything they've been told for 40, 50, 60 years is, this is not okay. So we have to give people the opportunity to make small choices, small good choices, and walk beside them as they're doing it, rather than, and honestly, like 4 years ago, I could have just stopped working with that guy and just, like, we're done. But when we're working with mental health challenges and people that have never, and intellectual disabilities as well, it's important that we build rapport before we start, like,
May I name what I think it is that you're describing?
Yes.
It's being trauma informed. It's kind of like the basics of like giving people choice and treating them with dignity.
Yeah.
So I agree that there's some room for improvement. in that.
Yeah. So that's all I have to say.
Thank you.
I was really sitting here going, oh, I'm just gonna keep my mouth shut.
You're fine. And Virginia apologizes. She had to go to work and she wanted me to apologize for leaving early. Natalie, do you have communication?
Sure, yeah, a couple things. One is, thinking about how to be more responsive to people with lived experience. I think that's part of why I was like, well, if people have anything to say on this topic, like, can we come out? I apologize for kind of jumping into that role, but I think I'm trying to, like, so many of these meetings are wonky and people have to come in the middle of the day, and it's like, I just, I guess I want people to feel like they can participate, even if they don't know exactly what the right way is. So I've been thinking about that with a lot of the meetings I go to and how to make it a little bit like easier for people to know when and how to jump in. Anyway, something since I spend like 90% of my life in meetings. How can I be here for more people? Especially when we're in the building. I've been, some of you may have seen in the news or else, that I'm doing a series of doing a series of interviews with healthcare providers and CEOs of hospitals and stuff.
Around the Maverick Union, a big article on that, yes.
Yeah, about healthcare provider recruitment and retention, and so this isn't specifically related just to behavioral health, although there are a few folks who are behavioral health related who talk to me, but mostly this is like family medicine providers, and that I kind of started this series because constituents bring up to me that they can't even find like a primary care provider.
Yep.
And particularly people with private pay insurance can't. And so those are the people who have a lot to say about it. So anyway, I started doing this series of interviews like more than 6 months ago, and so it's like, you know, hard to find a time to fit in like 80 hours of interviews. Over many months I have, and then I summarized what I heard and did a shorter presentation to our board of supervisors the other day. And I'm gonna do a longer one on Monday, January 27th. So I'm having an event from 6 to 8 p.m. It is almost entirely full with pre-registration, so there's a few spots left. I can send the registration link to send out to the behavioral health board if you'd like. So I'm encouraging people to register. We're not gonna be able to let more people in at the door, just because of the capacity of the space. Just thinking about holding an event during cold and flu season indoors. The venue can accommodate 225 people, and we're really close to that. But it will also be live streamed. So Access Humboldt's going to live stream it on their YouTube page. So their YouTube page is youtube.com/Access Humboldt. It'll be live streamed, and there'll be a chance for people who are watching the live stream to participate in there's a few audience participation questions through an online platform that I think will be pretty streamlined for people to use. So there's a chance to ask questions and give feedback, even if you're not able to be there physically in the space. So I can make sure to get the registration link out too. So this is again like centered around healthcare provider recruitment and retention, but it was no small feat to get like all the hospital CEOs and major clinic CEOs to agree to come. So the big feature, I think, I mean, my presentation is the kind of kickoff, but then we have these 8 panelists who are like, Tori Star and Michael Fellman and, you know, Redwood's Rural and all the, you know, not all, but many of the local hospitals and clinics will be represented. Humboldt City Research Center, and then our own public health officer as well. So it should be a good event if everyone here cares about healthcare access for our community. And so I hope that there will be a series of these given resources that the county is already planning another one for April, and I don't know exactly what the subject matter will be. And then I'm also working with Congressman Huffman and Senator McGuire and Senator Member Rogers on doing more of a town hall that they lead around reproductive health care and maternal care. So all topics that are getting people really fired up right now, which is good. Anyway, so that's what I've been devoting a lot of energy to, and I don't honestly know where it goes from there because one thing I will say is I'm looking at models for other communities that have like a healthcare consortium made up of both elected officials and people in that sector, so that they can work on addressing some of the more systemic issues that are barriers. And so I'm kind of mulling over in my mind whether we can create something like that, whether there's bandwidth and capacity to do that, and willingness on behalf of some of these healthcare providers. I will say partnership is down. Partnership Health has been really a great partner and discussion partner. So if anyone wants to kind of, especially folks who are really in the loop on this, have feelings that they would like to share with me about how to make this continue going. Now I feel the pressure of having taken on the topic and being the only elected official who was like, yes, yeah. Supervisor Ray, what are you gonna do now? I don't know. So I'm trying to come up with something better than I don't know. So maybe you all have thoughts that you want to share with me. And I'm also feeling the weight of not only this moment like that we're in right now collectively, but also the weight of like, wow, people are really having a lot of challenges around their health. And I'm sure all of you deal with it all the time. And it only, you know, like, the challenge that we face as rural community is big. So, you know, I'm preaching to the choir, but, so that's one thing. Vernon also reminded me very kindly that I had agreed to bring a peer support resolution recognizing peer support week in May, so for mental health month. And so I'll work with him and our court clerk on that. And if you'd like, we can like review the language here before it goes on, because there's some time between now and then, so I can work with you to just have the language there if there's any tweaks. But I think it would be great after the state one. I think that's all I have for right now.
Thank you, Natalie.
Thanks.
Thank you.
Marguerite, have anything? Communication?
Yeah, two things. One is, I already shared this, by sending it out to the SUDDR committee, but SAMHSA just came out with new guidelines for what they're calling special needs SUD treatment. And so that involves, I didn't see anything about, autism. I wondered about that when you were talking to Nat, but it involves things like people with certain handicaps, like not being able to hear. Also, people who only speak another language. Excuse me, such as like Spanish speakers or whatever. And, and I think it'd be good for all of us to look at that document, because it gives some really concrete ideas on how to not reject a person like that into an SUD program, but think about practical ways and affordable ways to accommodate people who have special needs, which, you know, I think is a really important thing. So that's one thing. Then that gave me the second thing that I want to talk about. I think everybody here is aware that, at least for a few months, I was on a mission to get to know different providers here. So I've gone out to different providers. I just want to assure everybody, based on what she said, that I went to Melissa's program and I saw no clients. I just met with staff. Of course, she passed clients when you were just walking, but I just came there. And then I went to the Two Feathers place, and two clients walked into the meeting and said, "We want to hear what you have to say, and we want to tell you what we're experiencing." And I thought that that was the most valuable part of the visit that I had, actually. But I'm really feeling like this is a good time, and I'm glad you said what you said, Danette. This is a good time to just think about the fact that, you know, our board and the SUD committee, et cetera, kind of has a mission to, you know, look at what we're doing and see how it can be improved and all that. And at the same time, we don't want to offend anybody. We don't want to get into anybody's face confidentially. And we certainly don't want to mandate anybody to talk to us. So it may be just a good time to figure out alternative ways. I like the idea of having lived experience people come, et cetera. But, you know, I think we need to talk about it more just to see how we want to do all that. And I'm not going to schedule anymore until we know. Because I sort of feel like I don't want to be doing anything that might be perceived as objectionable.
Thank you. I know that last SUD meeting didn't go because Michelle got in a car accident or something like that. So I know.
I hope she's okay.
Yeah. But it's maybe something to also discuss in that meeting. Thank you. Make a note, made a note of that. Yeah, do you have anything for us?
OD rates gone down.
Oh.
That's wonderful. Yeah, we are really excited about it. You know, it's a combination, I guess, of all the, you know, our candy push. you know, we're not really using the fentanyl, mindset that we were, because some areas have tested the supply, and there's not what we like, the lethal dose of fentanyl that we once believed or that was true is not what is around anymore. And so we're seeing less cases of xylazine. So it's a good thing, it's a good thing. So yeah, we're seeing a lot of youth overdoses in the hospital. Still, working on looking to expand withdrawal management services locally in the area. We are still, just looking and searching and planning on that. More will be revealed hopefully in the future. So that's all we have.
Thank you. Okay, that is all of us, and I'm going to pass. Reports, DJs.
She left a message there.
Or did she left a message?
On the
Back
chat.
and See what that says, but
She went to another meeting.
shout out to Natalie for the healthcare presentation. It was wonderful. Also, looking back to last year at the wonderful work that is happening in our community around behavioral health. Kudos to the staff doing all the work. Thank you. Thank you, Director. Behavioral Health Board Director. What you got?
Okay, well, I'm just really appreciating the conversation today, and Danette, what you lifted just around kind of having respect and treating people with dignity and thinking about experience, right, of people struggling with mental illness or SUD issues. So thank you for saying that out loud. Let's see, there's a few things that might be worth saying. One is, we're continuing to do equity work that feels really valuable, and it's kind of growing in some great ways. I think I've referenced a little bit of it here, but one of the things I think I'll just flag today is in our work with Kaufman and Associates, they also facilitate locally mobile crisis benefit implementation. And they've been doing some sessions with counties and tribes together. And so we recently went to a meeting out at UIHS, Paul, Kaylee and I, and Jeff joined by phone and talked a bit about just how do we better coordinate care, especially in the mobile crisis arena between tribes and counties. And so that work I am feeling really positive about, and we have another meeting later at the end of this month with people from UIHS, some other local tribes, Kaufman and Associates, and also some DHCFTA people, so like technical assistance people, to help us just think together about how we partner and coordinate services and do that work better together. So I wanted to flag that. I want to just recognize, because it's an ongoing issue, that we continue to struggle with budget deficit, and how do we do all the work that we need to do with limited resources. And one of the things I feel like it's important to say is that we're, now in 2025, and yet we're still working on understanding fiscal year 23-24, which is a while ago. And so it's just, I feel like it's a challenge for us as we talk about MHSA changing and think about the new initiatives rolling out that are unfunded or underfunded, and continuing to want to do all the things for our community that's needed, and recognizing we don't have resources to do all the things for our community that's needed, which is partly why we partner, but it's still, sometimes I just feel like we continue to fall short, and I want to say that. And the third thing I thought I would mention, which is kind of a mixed bag, it's a positive thing, but I want to add an element to it, is we have many projects that we're lifting up that are very exciting and successful. We talked about Hyperion. We're working on the mobile crisis or behavioral health crisis triage center in partnership with Mad River, which is amazing. We submitted an application for a new SB. So there's lots of things that we're coming together as a community to do. We also recently opened the doors for an adult residential facility, Lighthouse, and that's awesome, amazing, and we have referrals and people residing there at this point, and it really helps our system of care locally. And we had some pushback from that community, and I want to talk about that, not be for no other reason than to just acknowledge that in our community, we really still struggle with stigma and discrimination, and we still have, you know, pockets and people who I think don't fully understand, you know, the experience of people with mental illness, or easily make assumptions, not ill-intentioned necessarily, but easily make assumptions about what does it mean to have mental illness, or what does it mean to have substance use issues, like not recognizing the underlying trauma. I think that that's where our community sometimes loses track, is that people suffering have trauma, right? And so I'm saying it to this group because I feel like you all are allies in this work, and how do we do this work better together to make sure that we're sharing with the community in ways that increases understanding and compassion and kindness, and just like furthers what I think I experience in pockets of really great support and kindness to these populations. And there's more work to be done. So I just want to say it and thank you all for the work that you do with us, because I see it and feel it every day, and there's more for us to do together. So
Thank you.
I just want to say, you all really took it on the chin. I'm sorry.
yeah.
I'm really sorry that all happened the way it happened.
And I want to say, because a couple of us were there, that this group, this person, everyone from THHS was so amazing. I could not have done that. I could not imagine being there for 2 hours and 21 minutes.
Yep.
And taking that and just having a kind response and face to all of that. That was incredible. I will hold that in my mind for a long time as a goal. I could not do this time, but.
Well, thank you for that, and for like being there to speak about people with respect and kindness. I heard such good things. About y'all and about Jacob Rosen and
Yeah.
It's nice. There was like a silver lining, but I'm
yeah.
deeply sorry that that was allowed to happen that way. Obviously, nothing I could have done about it, but still.
So anyway, appreciation for you all. Thank you.
Thank you.
Well, thank you. Thank you.
Do you have anything, Paul?
Well, just some of the normal stuff that's still moving forward, like our diversion contract with Department of State Hospitals, they're still moving forward. So we have 2 contracts in the works, one for our permanent diversion program in felony incompetence here locally, and also a community-based restoration program. So we're excited about that. Getting those up and running. We'll most likely be contracting out the community-based restoration program. We've had, as you know, we've mentioned that we had a focused audit previously, so we still haven't received our corrective action plan for that, or our final report, whatever that might be. But we did get a corrective action plan on our network adequacy, and timeliness component of our service. So we're actively working with DHCS on our corrective action plan. So we submitted for last week. And we'll see, we're meeting with them regularly, so hopefully we can resolve that corrective action plan quickly and continue on with other things. So, but other than that, I don't think I have anything else.
And that corrective action plan will, at some point, we'll be able to read like what happened and the response and all of that.
Sure, yes, absolutely.
So I know it's been a while. It feels like
It's been forever.
Yeah.
So,
Yeah, our QI department's been very busy, continues to be very busy. Amy Cohn is heading up that department right now. We are looking for an additional manager to take over Kaylee's vacancy that she had in that program. So, but Amy's doing a great job of trying to manage all of the changes that have come from her state, from her DHCS. So it's a lot of work, but they've been very busy and active. But it'd be nice to schedule a time for them to come and do an overview at some point, to the board on activities, that you guys been a part of, over the last year, so it might be good in that meeting or in that presentation, they could definitely talk about the audits and reviews and findings and, changes that have come from that.
All right, put that on the list. Thank you. All right, we have 15 minutes.
Did Kaylee have a?
I don't have anything to add, but because I think everything kind of rose to the surface today, but if anyone has questions. Yeah. Thank you, Kelly.
I wonder if we should put you on there as a
Yeah.
regular reporter.
Sure.
That would be awesome. Okay. So SUD committee, didn't meet last time. I don't know if there's anything to report. Nothing. Okay. At this time, we have no other committees other than executive that are going, but I hope that soon we will be having a children, family, and some point in old people one. Oh, I'm sorry. I mean, older adults. Elderly. Well, it's
No, the silver.
the silver haired committee. We have some people, sorry if I was inappropriate, my apologies.
I'm here to keep you in line.
Thank you. Chairperson, I have nothing other than okay. I have something. I just want to continue to say, our behavioral health board, our county is doing a really good job. When you look at other counties across the state, we just have to remember that. And I remind people, or when people complain to me, I always bring that up. So I'm appreciative of what you do. And Vice Chair, do you have anything?
No, just another comment along that line, as I think back 10, 15 years ago, the discussion, the information shared, the things that are going on, they become more complex, more sophisticated, deeper into issues than we've had before as a board, those kind of discussions. And I really appreciate that. I remember a decade ago, we're trying to find ways to do that, have more in-depth and substantive discussions about things. And I will let you know, I really see that in my perspective.
And Navigation Center, Care Court, do we have anything on Navigation Center? I don't think there's anything now.
May I just add something about Care Court, just from a provider or perspective?
Yes.
Just, it happened to be a Yurok tribal member where I work, was the first Care Court participant, so I've had some experience walking through the process. And there were some kinks for sure, but I really appreciated DHHS and the staff from behavioral health, Ben Beach in particular, and also Heather Cooper from County Council, learning to navigate how, like, because the tribes are required to be notified when a tribal member's been petitioned to court. So I was able to attend the hearing for the individual, and I have some concerns in general about some of the petitions that are being made in regards to people that probably need a higher level of care. And I get that Care Court's going in a direction where we're going to hopefully catch people sooner before they become so destabilized that it's hard to rein them in. But I've had some discussions with Kelly Schwartz at the Public Guardian's office and about, we're not there yet, obviously, but down the line, I see Care Court really having the potential to have more upstream interventions. I fear though that people that do need like conservatorship being funneled through Care Court first to see if they can do it or not is creating like an extra barrier to people getting the care that they need. And so the person that's been petitioned and referred to Care Court immediately destabilized once they were released from custody. And I just wanted to put it out there. There's great work being done. I really, from you're a tribal employee, I appreciate the communication. from DHHS staff. And I'm interested to see how it continues to. But yeah.
Yeah, we have 5 petitions, so far, from Care Court since December 1st. So, yeah, Kelly was first.
Yeah.
Yeah. So, yeah, we're learning a lot. We're fine tuning, we're creating policy and procedures to help the process. But, you know, it's just another element here in play for us. And hopefully it won't be a barrier for the appropriate level of care. Of course, we want to make sure we're getting folks to the appropriate level of care.
The least restrictive is
absolutely
best when it's appropriate.
Well, and good feedback, like, thanks for the feedback,
Yeah.
because we need that, so. yeah.
Yes.
Future items. I've noted several. Does anybody else have any future items? For the greater good? Yes, yes.
Hope you knew what you were signing up for, having me join the board.
You just wait.
Well, do your future items include, I heard the topic of like a peer lived experience ad hoc committee or something like around how to include lived experience. I just wanted to put out there that's something I would be interested in participating in if it was
That's been
something we chose to
issue
do.
Bernard has brought up again and again.
Yeah.
And so touch base with them, and I'm, you know, part of that conversation as well, to find the right way,
Sure.
you know, so that we hear, and listen to lived experience.
Okay, got it. Annette?
I would like to, ask, so a new life discovery, director can come next month to this meeting. They were, scheduled to do the substance, but, they would like to come and share what they, it's been a topic that keeps coming up, so.
So when you, when anybody has something that they want to be on an agenda, it needs to come to the executive committee. So you can email me, email Joe, say, I would like this on the agenda. It goes to the executive committee and then we create the agenda. So, and we have some quarterly like themes that are mapped out. So whenever you have something like, oh, I want to hear this, send an email, send it to Joe, and then not saying it'll immediately get on there. Sometimes we're already scheduled a few months out, but it will be, you know, noted.
Adding to that, we want more people to come with requests. Cause we're trying to, as an executive committee, figure out, well, what would be a good presentation? What do people know? What have they not heard about? And again, over the last decade or so, I don't remember very many people at all saying, why don't you have a presentation? So bringing that information to us is cool.
Yeah, so I've got some veterans that services that want to present and new life, so just need to get those on the agenda. Anything else?
FHSA in May, potentially having the public hearing.
Okay.
I don't know, Kaylee, if you wanna maybe shoot for that happy presentation, the same day they're meeting.
Yeah. Dana Taylor?
Yeah.
Okay, so, yeah, I did make a note of that. We'll get it. Yeah, that.
Having a thought, would you all, regarding HTTC recommendations for behavioral health board, we have a slideshow that we presented to the behavioral health board before. Would it be helpful for us to give like a full presentation about that?
Do you remember that? Tim?
Been a while, and there's,
Right? Oh, 2019.
there's so much, and things are involved with it. Sometimes it's kind of overwhelming for us all to take in. But I think it would be good if I hear you saying, let's have another presentation and maybe bring core activities or priorities to us. If we have 20, 30 minutes, we hear what's happening and get us engaged. Does that make any sense?
Sure, so.
I don't always make sense.
Kelly had a comment. Did you have?
Oh, I just, when it came up earlier as a brand new behavioral health board member, I would love to hear what the recommendations are. And so I would appreciate a presentation if it was about the recommendations. Is that what you're
Yes.
saying? Yeah.
Okay, so how about this?
Or a report is fine too, but.
Um, let me get back to you on that, if that's okay. And I have a note, recommendation recap. And I do believe that we talked in our meeting, that we will have an orientation as soon as these, a retreat, we called it, with excellent snacks, by the way. Once you two are approved, we'll do another retreat with a certain number of people.
Okay.
Kind of, do a recap.
Yeah, I want to underline, it's really important if we can get together for a couple hours and get to know each other.
Yeah.
I just believe if I don't know you, you don't know me, how is our conversation going? So
Yep.
it's a cool thing to do.
Okay, and with that, because I am committed to ending this meeting on time or a few minutes before 14:12. Thank you so much, everyone.
Great meeting.
Really appreciate it.
Let's meet her.
Yeah, here we go.
Don't forget the demographics. You know, I have, yeah.